Improving clinical outcomes, implementing the Deterioration Index predictive model. Clinical deterioration in the inpatient setting happens rapidly and often results in adverse patient outcomes such as cardiac arrest and mortality. Survivors often have a longer length of stay, and they also incur increased cost when experiencing deterioration while admitted to the hospital. Predictive models embedded in the EHR use discrete data to identify risk often sooner than could be detected by human assessment alone, and they can prompt clinician action, both actively through real-time alerts and passively by display of risk scores throughout the EHR. Our aim was to implement the EPIC-based Deterioration Index predictive model to support early assessment and intervention for patients experiencing clinical deterioration and improve associated outcomes. The DI model uses dynamic patient data to identify early signs of deterioration, predicting the likelihood that a patient will experience an adverse event. The DI improves on traditional early warning systems by including additional data points and using an algorithm that is more accurate than the simple arithmetic used by other early warning systems. To support our aim, a multidisciplinary task force was formed to evaluate system readiness and design a framework for model implementation using a combination of improvement science, adaptive leadership, and data analytics. An alert response workflow was designed by the team, merging predictive technology with human factors. The active alert workflow is designed to encourage immediate response, and nurses are expected to assess patients and document vital signs within 30 minutes of receiving the alert. Post-go live, multiple rapid PDSA cycles were conducted to optimize workflow and data collection. The project timeline consisted of 4 main interventions: go live, comprehensive refocused system education, critical care resource nurse workflow optimization, including proactive rounding, and a threshold change for progressive care unit patients. An Epic dashboard was created to monitor meaningful metrics specific to DI performance, and outcomes were tracked monthly to assess effectiveness. To assess the impact of our interventions, a baseline median was calculated using the first 4 months of data following implementation, reflecting the period during the project when the active alert was turned on but comprehensive staff education had not been completed. The baseline median was recalculated for the 8 months post-education. During that period, an improvement in mortality for patients triggering alert was observed, with a decrease in mortality from 24.5% to 19.7%. This was confirmed by observation of 6 consecutive data points below the baseline median following the intervention. Over time, this improvement translates into 153 lives saved. A similar decrease in mortality was observed when the critical care resource nurses proactively rounded on patients for an elevated DI score. Mortality for this group decreased from 15.5% to 13.8%. Cardiac arrest mortality for patients with a DI alert also decreased from 76.9% to 72.7%, and an overall decrease in cardiac arrest for patients triggering an alert from 7.6% to 7% was observed. We encountered a few adaptive challenges during the course of this work, including limited understanding of predictive model functionality intent on the part of our nursing staff, strong attachment to static warning systems, leadership transitions, and unclear ownership at times. We also implemented the predictive model during COVID-19 and experienced difficulties with clinical resources and turnover. Our primary key learning was that when coupled with organized and well-designed system response, predictive models can improve outcomes. Predictive models should be employed in the background for an extended period prior to converting to an active alert to make sure to establish that robust baseline. Implementers should consider the role of both active and passive decision support in facilitating early recognition of deterioration and design workflows that consider both. The team should also ensure organizational commitment to the adoption of technical tools required for alert delivery. We had originally planned to deliver our alerts actively via mobile technology and realized into the project that our users weren't utilizing that functionality as much as we thought. We also learned that adaptive challenges such as alert fatigue and hesitancy to abandon historical early warning scoring tools can be overcome as long as the alerts are well designed and ongoing communication of predictive model performance occurs to build trust with clinical users. And lastly, be transparent and hardwire education.
Thanks for listening. If you have any questions or comments or suggestions, please reach out at the contact information listed on the screen. Thank you.